Okay guys, this is the first time that I will give a lecture just staring at my computer without an audience to interact with, so we'll see how it goes. I will be available on the actual day of the lecture if people have questions or want to go through the PowerPoint in person. I'm happy to be there during that time on March 23rd. So today we're going to talk about peripartum hemorrhage. Just a quick ACE review question. Uterine blood flow at term pregnancy is A, 50 milliliters per minute, B, 250 milliliters per minute, C, 700 milliliters per minute, D, 1100 milliliters per minute, or E, 1500 milliliters per minute. And the answer is C, 700 milliliters per minute. Uterine blood flow increases from 50 to 100 milliliters per minute before pregnancy to 700 to 900 milliliters per minute at term, which is a greater than 1 unit of blood per minute, and 90% of this goes to the intervillous space. When you're dealing with peripartum hemorrhage, denial is your worst enemy. Hemorrhage is a major contributor to maternal morbidity and mortality. And when you're starting to see tachycardia and hypotension, this may be mistaken for responses to neuraxial blockade or an oxytocin infusion. Additionally, they might be late findings in otherwise healthy young trauma patients, and this represents also our OB patient population. But you start to see these abnormal vital signs and you say, this is probably due to my neuraxial blockade, or, oh, I'm running the oxytocin pretty quickly, that's probably why they're tachycardic and hypotensive. But now you're turning towards your second stick of phenylephrine, and it's time to start thinking about other reasons why that might be happening and communicating with your colleagues across the drapes to make sure that everything's going okay from their standpoint. Prevention, early recognition, open communication, and prompt responses are key to improved outcomes. Anesthesia providers, obstetricians, and labor nurses frequently underestimate blood loss at delivery. Heavy bleeding may increase the error of the estimate. So as bleeding becomes more intense, we get worse and worse at estimating how far behind we are. And this leads to inadequate replacement of intravascular volume. Some basics just in your approach to peripartum hemorrhage. You want to do risk assessment and modification. We're going to go through each of these through this PowerPoint, and then again, if you do come to the lecture and have questions, or feel free to email me if you have any questions as we go through. But risk assessment and modification, general institutional preparation for peripartum hemorrhage should be in place where you're working. Diagnosis, management algorithms, logistics and communication, hemostatic intervention, and replacement therapy. So we're going to start with risk assessment and modification. Ideally, this happens in the antepartum period. So we really do depend on our obstetricians to take note of any patients that they really feel will be at risk for peripartum hemorrhage, identifying those patients and then modifying their risks early on in their pregnancy, and possibly creating a care team conference to better manage these patients. Examples of this might be if you identify a patient with maternal anemia and say they're iron deficient, starting them on iron supplementation will help modify their risks. Patients with abnormal placentation or other antepartum or peripartum or postpartum hemorrhage risk factors, which we'll go through in more detail in a moment. Management of coagulopathies, so patients that have inherent iatrogenic or acquired coagulopathies, managing those ahead of time. Again, creating a multidisciplinary approach, calling consults, and asking for help. Additionally, in this part, I would like to also bring up identifying patients that may refuse blood. This is really important to start the conversations early about whether patients will or will not receive blood. Examples of this may be our Jehovah's Witness population. Understanding what blood products they will or will not accept, taking the opportunity in the clinic in times where there is no stress related to their consent for these types of therapies, and also having individual conversations, trying to get the patient by themselves away from family members to really understand what their beliefs are, what their attitudes are towards blood products and receiving blood or not receiving blood, and having very thorough documentation and consent for what they will not receive is very important come time for the delivery portion. When patients tend to be a little bit more in duress, they're not able to fully think about what they want to have happen. Some patients are very clear on their wishes, and some need help from their ministers or their members of their church to help guide them, or they just need time with their family or with themselves to think about what they want. All of this, again, can take place ahead of time so that then when it comes down to the delivery, everybody's on the same page. So in that risk assessment, we want to know who are the patients that are at risk for peripartum hemorrhage. Antepartum hemorrhage, major causes of this are placenta previa, placental abruption, uterine rupture, and vasa previa. Placenta previa is when the placenta is attached close to or covering the cervix, which is the opening of the uterus. It occurs in about 1 in every 200 live births, and there are 3 types, although this terminology may be changing mainly based on ultrasound availability. Now that we have ultrasound and ultrasound is so good, we are able to identify just specifically how many centimeters the placenta is from the cervical os. So you either have a placenta previa or you have a marginal placenta previa or not a placenta previa, basically. Sorry, let me go back. You either have a previa or you don't have a previa, and if you don't have a previa, the placentation or the border of the placenta is then thoroughly documented in terms of how far it is from the cervix. Again, it happens in 1 in 200 pregnancies. The etiology is unclear. It's associated with multiparity, advanced maternal age, smoking, cocaine use, prior C-section or other uterine surgery, and a prior placenta previa. Remember to consider placenta accreta when you see that the patient has a previa. Classically, these are described as painless vaginal bleeding during the 2nd or 3rd trimester. That being said, blood is a uterine irritant and will cause contractions, and contractions can be painful. So even though in the stems for questions on your exams, you will often see the painless vaginal bleeding, clinically, patients may have pain associated with contractions due to their placenta previa. OB management, the diagnosis is by ultrasound. Management depends on the severity of the bleed, maturity of the fetus, the state of labor, and additionally, the patient's access to care. So they may manage these patients in an outpatient setting if the patient has good access to a medical center, if they're reliable, if they've been shown to be compliant with recommendations. They will be given betamethasone for fetal lung maturity. If they are contracting and they're trying to get into the window where the steroids are, when they're in the steroid window, they may do tocolysis or a blood transfusion as needed or clinically indicated. A C-section is scheduled. Timing of scheduled C-sections for placenta previa are between 36 weeks and 0 days to 37 weeks and 6 days. That is if they don't present sooner, having some large bleed requiring urgent delivery. The risk to the fetus is uteroplacental insufficiency. The blood supply to the lower uterine segment is worse than the other areas of the uterus, and preterm delivery prematurity. Placental abruption, complete or partial separation of the placenta from the decidua basalis before delivery of the fetus. Maternal hemorrhage may be revealed by vaginal bleeding, or it may be concealed behind the placenta. Fetal compromise comes from uteroplacental insufficiency. Associated conditions for placental abruption, hypertension, preeclampsia, advanced maternal age and parity, maternal and paternal tobacco use, cocaine use, trauma, premature rupture of membranes, chorioamnionitis, bleeding in early pregnancy, history of previous abruption, and hospitalization for both acute and chronic respiratory diseases. It complicates about 0.4 to 1% of pregnancies. The presentation is vaginal bleeding, uterine tenderness, and increased uterine activity. Again, blood is an irritant. It's associated with a non-reassuring fetal heart rate, depending on the percentage of the placenta that has abrupted and depending on how depending on the blood supply to the placenta and to the baby. In a concealed abruption, vaginal bleeding may be absent, and there can be a gross underestimation of hypovolemia. Diagnosis is primarily clinical. Ultrasound is not very good at identifying the amount of bleeding, the amount of abruption, so this is a clinical diagnosis. Complications of placental abruption include hemorrhagic shock, acute renal failure, coagulopathy, and fetal compromise or demise. This is the most common cause of DIC in pregnancy. The rate of IUGR associated with abruption suggests that some cases of placental abruption are the result of chronic long-standing placental abnormalities, also suggestive of the associated conditions such as hypertension and preeclampsia. Major risks to the fetus are hypoxia and prematurity. Uterine rupture. The incidence is less than 1% in parturients with a scarred uterus. Associated conditions include previous uterine surgery, trauma, inappropriate use of oxytocin, grand multiparity, uterine anomaly, placenta procreta, tumors, fetal anomalies. It has a variable presentation. True uterine rupture should be suspected when vaginal bleeding, hypotension, cessation of labor, and fetal compromise are present. Fetal heart rate pattern is the most reliable sign of a uterine scar dehiscence or rupture. Vasa previa is a filamentous insertion of the fetal vessels over the cervical os. Fetal vessels traverse the fetal membranes ahead of the fetal presenting part. The fetal vessels are not protected by the placenta or the umbilical cord. Rupture of membranes is often accompanied by tearing of the fetal vessels, which may lead to exsanguination of the fetus. This is a picture of vasa previa. And these are the fetal vessels that would be unprotected, and the head can be compressing these vessels, as well as that they are vulnerable when you get your rupture of membranes. It happens in 1 in 2,500 deliveries. There's a high fetal mortality rate of 50 to 75%. Remembering again that blood volume of a term fetus is 80 to 100 milliliters per kilogram. Vulnerable fetal vessels may be compressed by the presenting part, as I just stated, resulting in fetal hypoxia and death. It's associated with multiple gestation, particularly with triplets. Diagnosis is made by ultrasound. It is extremely sensitive and extremely specific. It should be suspected when bleeding occurs with rupture of membranes, but this is often too late. Early diagnosis and treatment are essential to good fetal outcome. Obstetrical management, some OBs hospitalize the patients between 30 and 32 weeks gestation, just to make sure that if there is preterm premature rupture of membranes, it's in the hospital. It is a true emergency. It is a fetal emergency. The mom will likely do okay, but the baby will, again, exsanguinate if not immediately delivered. C-section for these patients is scheduled at 36 weeks if everything else is uncomplicated. A ruptured vasa previa, again, true obstetric emergency, immediate delivery of the fetus, almost always by C-section. Neonatal resuscitation requires immediate attention to neonatal volume, replacement with colloid, normal saline blood. Postpartum hemorrhage. Major causes is the 4 T's: tone, trauma, tissue, and thrombin. Tone, tone, tone. Atney, atney, atney is what Archer used to say. 80% of postpartum hemorrhage is due to uterine atney, 15% due to trauma, 4 to 5% due to tissue, and thrombin or DIC related issues is less than 1%. Causes of uterine atney include a big uterus, multiple gestations, polyhydramnios, fetal macrosomia, tired uterus, grand multiparity, prolonged augmented induction, a sick uterus, including choreo, iatrogenic agents, including tocolytics and volatile agents. The uterotonics that we use, oxytocin, the dose is 20 to 60 units per liter, IV infusion. There are no contraindications. Side effects include decreased SVR, free water retention. It has a short duration of action. Next is your Methergin. The dose is 0.2 milligrams IM. Remembering that you're going to take your TB syringe, but you're going to use the longer needle that is not attached to the TB syringe in the package. And to make sure that you're getting intramuscular these days, we are not actually getting into the muscle with a small TB needle. It's also, luckily, both for Methergin and Hemabate, the dose that is required is the dose in the vial, which makes it very simple. Just remember that it's given IM. Contraindications to Methergin include hypertension, preeclampsia, coronary artery disease. Side effects include nausea, vomiting, arteriolar constriction, thromboembolic events. It has a long duration of action. It may be repeated once after an hour. I find that we probably do repeat it a little bit more frequently, probably every 30 minutes by the obstetrician's instruction, but just remember that this is both by Chestnut and Hippocrates that suggests that it just needs to be repeated every hour. Hemabate is 250 micrograms IM. It is contraindicated in patients with reactive airway disease, pulmonary hypertension, hypoxemia. Side effects include bronchoconstriction, shivering, increased temperature, and diarrhea. It may be repeated every 15 minutes to up to 2 milligrams. Cytotex, is 800 to 1,000 micrograms per rectum. There are no contraindications. Side effects include shivering, increased temperature, diarrhea, nausea, vomiting. Often this is administered by the nurses. After tone, we have trauma. This is from cervical, vaginal, or perineal lacerations. This is most common in assisted deliveries or surgical technique or with uterine inversion. Surgical technique just being that they have surgical bleeding during a C-section. They might have extended their uterine incision, their uterotomy too wide, getting into some vessels in the lateral walls, for example. Tissue, it's commonly caused by retained placenta. In 3.3% of deliveries this occurs. Additionally, in the category of tissue comes your abnormal placentation, which includes your placenta accretas, your incretas, and percretas. An accreta is adherence of the placenta to the myometrium without invasion of or passage through the uterine muscle. An increta is invasion of the placenta into the myometrium, and percreta is invasion of the uterine serosa or other pelvic structures. Here's just a picture of those different abnormal placentations and the incidents in which they occur. This table was taken from an article from 2011. Just to give you some perspective, when you start to see these women that are coming in for their fourth C-section, you just want to keep your, levels of suspicion high for the existence of an abnormal placenta. As you can see, if a patient has had one cesarean section without a previa, the incidence of having a placenta accreta is 0.03%. If a previa is present, it goes up to 3.3%. Again, going back to the presence of a previa, you want to keep in the back of your head whether they have a placenta accreta. If the previa is present, it goes from 3.3% to 11% with the second C-section. and 40% with their third C-section. So I don't need to keep reading these numbers, but basically just keep in mind when you see a placenta previa, you do want to make sure that the assessment has included ruling out placenta accreta. The placenta accreta is one of two leading causes of peripartum hemorrhage and is the leading cause of peripartum hysterectomy. It occurs in 1 in 530 to 1 in 2,500 deliveries. Risk factors include prior C-section or uterine procedures, short C-section to conception interval, advanced maternal age, and smoking. 20% have no identifiable risk factors. Diagnosis is made by ultrasound, and MRI is often used for further characterization. C-section delivery and often an obstetrical hysterectomy are the methods of delivery. This is scheduled between 34 and 35 weeks and 6 days. They want to schedule it earlier because the risk of having early preterm labor leads to a more emergent setting, whereas these patients do much better if there's a scheduled C-section where everybody is ready and able to manage these cases. If you are not at an institution with an ICU with interventional radiology, urology, blood bank support, gyn-onc, things like that, these patients do better managed at a higher level of care. So often we get these patients as referrals from other institutions that do not have these capabilities, which is why we get a lot of these more so than other institutions. The final cause for postpartum hemorrhage include thrombin or coagulopathies. These can be congenital or inherited coagulopathies, including von Willebrand's disease or other factor deficiencies. They can be iatrogenic coagulopathies, patients on anticoagulation for various reasons. Acquired coagulopathies would include placental abruption, preeclampsia, amniotic fluid embolus, fetal demise, sepsis, and fibroids. Delayed response to hemorrhage or other cause can lead to a consumptive coagulopathy as well. So pregnant women, when they hemorrhage, are more prone to developing DIC than other patients. DIC, abnormal activation of the coagulation system. You get an increase in your thrombin formation, depletion of your coagulation factors, activation of your fibrinolytic system, and hemorrhage. Lab findings include decreased platelets, decreased fibrinogen and antithrombin 3, decreased PT, PTT, D-dimer, and fibrin degradation products. Management includes removing the offending agents, correcting factor deficiencies, and other indicated supportive care. Just to remember, fibrinogen levels in non-pregnant patients is about 230 to 490. In the third trimester of pregnancy, it is significantly or elevated to 370 to 620. So sometimes the lower end of normal of a fibrinogen level may be abnormal for a pregnant woman. So you might be seeing a consumptive process in that time. PT in a non-pregnant patient is 12.7 to 15.4, and in the third trimester, normally the PT is 9.6 to 12.9. Again, these patients are hypercoagulable at baseline. D-dimer in a non-pregnant patient is less than 500, whereas in the third trimester, a D-dimer is 130 to 1700. So moving on, now that we know who's at risk, how we can maybe help identify these patients so that we can be prepared, so that we aren't dealing with a hemorrhage in a surprise situation. You don't want every time to be the first time. So peripartum hemorrhage should not be like Groundhog Day, that when you have a patient bleeding, everybody's learning how to manage it for the first time. So having plans in place and practicing drills improves maternal fetal outcomes. We do have a UCSD OB hemorrhage protocol. You can find the full reference on Epic, also on the UCSD intranet under clinical web references, and there's also a red binder at the OB nurses station if you want to refer to that and find out what the actual policies are. Below, I just have an example of some of the things that start happening the minute that the patient is identified as having a hemorrhage. For patients that are antepartum, they increase the IV fluids, they start a second IV, they notify the OB provider and the anesthesiologist, they start obtaining vitals more frequently, they ensure blood availability, they send a specimen for coagulation studies, they convert any type and screen to a type and cross, and they send a second specimen to the blood bank. They draw labs that include PT, PTT, INR, fibrinogen, and they do a wall clot in OB. They start to weigh the pads and the chucks to get some idea of how far behind we are. If they are not on fetal monitoring, they will be placed on fetal monitoring. And then they prepare the patient and the family for possible transport either to L&D if these patients are on the 4th floor, or for transfer to the OR if they need to have an emergent intervention. If they are far away from labor and delivery or the OR, they may call a code pink just to get more support over to manage the patient. And they do call the blood bank and initiate the OB hemorrhage protocol with the blood bank as well. Diagnosis. Basically, it's just all about communication. So you want to just make sure that when you are seeing some of these unstable vital signs, don't let hemorrhage be a last resort thought when you're too late. So as you're watching patients, watching them, if they need more support than what your usual patient is, it's time to look over the drapes, take a peek at what's going on, look at the canisters, ask your obstetricians if they're having difficulty with hemorrhage, ask about the tone, ask about surgical bleeding, things like that. These are just rough estimates for what we can approximate when we are dealing with bleeding in the operating room. And then remembering that your labs will lag. So if you draw acutely, if you draw your CBC, it may not reflect actually how far behind you are until after resuscitation. Management algorithms, logistics and communication. Anesthesia for peripartum hemorrhage. So this is through your management. You want to do a fast targeted assessment, especially if you're being called as a consultant while the patient is hemorrhaging. You want to get a relevant past medical history, OB history, including prior C-section. Again, if they have a previa, have they been ruled out for a CRETA, things like that. What medications are they on? This is to include magnesium, which can be associated with uterine atony. It also affects your management if you do a general anesthetic, as magnesium will potentiate the effects of your neuromuscular blockade agents. And you want to find out about allergies. A quick physical exam, you want to look at their airway. In a crash situation, you will be putting these people to sleep. IV access and assessing their intravascular volume status. You can also look at their back, make sure if they do have an epidural, where is the epidural in relation to where the loss of resistance was from the initial procedure. Checking to make sure that they have a block if they need to go back, things like that. Having a CBC, again, making sure that there's a type and cross if they're actively bleeding. And your anesthetic choice is just going to depend on the urgency of the situation, what the hemodynamic status is of the mother, what the labs are. If you do not have labs, and this is a situation that can be associated with DIC, you do not maybe want to place a neuraxial blockade if you don't know what their coagulation status is, if there is concern for a developing DIC. Your options are regional versus general. And again, this decision just is based on all the things that I just mentioned. If this is a crash C-section where the mom or the fetus are at risk, oftentimes we do a general anesthetic. General anesthetics are done with a rapid sequence induction, pending any difficult airway scenarios. Recognizing that pregnant women are full stomachs, that we do a rapid sequence induction, that they have difficult airways, both from the progesterone effects and the increased volume effects, leading to mucosal airway swelling and edema, and narrowing of their airway, making passage of the ET tube difficult. I guess additionally, pregnant women have weight gain. They have breast enlargement and making DL potentially difficult. Additionally, they have a decrease in their functional residual capacity. They have an increase in their oxygen consumption and an increase in their CO2 production, all leading to increased risk for hypoxemia. Other special considerations when you're dealing with bleeding: avoiding hypothermia. Hypothermia is associated with a decreased synthesis in acute phase proteins and clotting factors. Every 1 degree Celsius drop equals a 10% reduction in coagulation factor activity. Hypothermia slows the coagulation cascade and prolongs clotting time. It decreases citrate metabolism as well. Avoiding metabolic acidosis, which decreases thrombin generation. A pH from 7.4 to 7.0 reduces activity of factor 7A tissue factor complex by about 55%, and prothrombinase 10A and 5A complex by 70%. It additionally impairs the coagulation cascade. And then treating hypocalcemia, which leads to coagulopathy, decreased SVR, arrhythmias, etc. This is especially associated with patients that are receiving large transfusion loads. The single biggest problem in communication is the illusion that it has taken place. Please, please, please communicate with your surgical colleagues. This is not just an OB, this is in every surgery. We are on the same team. If you have concerns, it is important to identify those concerns and communicate them. Sometimes the surgeons see things that we do not see, and sometimes we see things that the surgeons do not see. If they see the vitals are stable because your heart rate is okay and your blood pressure is okay, but the patient is on 100 mics of phenylephrine, things are not going okay, and they might not know that. So we need to communicate with our surgical colleagues. In a hemorrhage situation, there are certain hemostatic interventions that can take place. These things include invasive therapies that are often initiated by other practitioners, including the obstetricians or the interventional radiologists. They can put uterine compression sutures in. Patients can be transferred to IR and undergo arterial embolization, surgical ligation, intrauterine balloon tamponade, and hysterectomy. This is the B-Lynch suture. So basically they just tie the uterus down and create tone artificially with these sutures. They are resorbable, so they will close the abdomen, and it does not preclude future pregnancies. Internal iliac artery balloons. These you will often see for scheduled placenta accretas. The patient will go down to IR before the surgery and have these placed, remembering that the left groin access will go to the right internal iliac artery and vice versa, so they cross over, likely just due to access for the interventional radiologist. In these cases, when you do your time out for the procedures, you want to identify who is going to be the person inflating the balloons and do they know where they are. This person should not be you, because at the time of hemorrhage, you are likely going to be resuscitating the patient. So more often is going to be a circulating nurse in the operating room. This should be, again, discussed in your timeout so that it is not a big scramble when they want the balloons inflated. And that person should be able to identify where the syringe is very easily and quickly. Intrauterine balloon tamponade, the Bacre balloon, increases wall tension across the uterine wall, which tamponades hemorrhage. And then your replacement therapy. This is where we do come into play. UCSD massive transfusion protocol. It's designed to ensure adequate supply of blood components for patients whose transfusion requirements exceed 10 units of RBCs in a 24-hour period of time. When invoked by the physician, plasma and red blood cells are supplied on a 1-to-1 basis in 10-unit groups, along with 1 to 2 units of apheresis platelets for each 10 units of RBCs and plasma. Quick UCSD transfusion facts. Our PRBC volume here at UCSD is 300 to 400 mLs. The hematocrit is 55 to 65%. 1 unit should increase the hematocrit by 3% or a hemoglobin by 1 gram per deciliter. Neonates typically receive CPDA1, red blood cell volume, which is 225 to 350, and the hematocrit of that blood is 70 to 80%. Our FFP includes the coagulation factors and proteins. It has 10 to 25% lower factor V and factor VIII. The volume is 202 to 250 mLs. 1 unit raises coagulation factors by about 7%. Cryoprecipitate is a fraction of FFP enriched in fibrinogen, von Willebrand's factors, and factors 8 and 13. The volume is 10 to 15 mLs. The dose is about 10 to 15 units. Platelets here are apheresis platelets from a single donor. They equal 6 to 8 units of whole blood-derived platelet concentrates. The volume is 200 and 400 mLs, and it raises the platelet count by about 60,000. Red blood cell content of platelets is less than 0.003 milliliters and is deemed insufficient to cause primary Rh immunization in most Rh-negative patients, which is of importance in our pregnant population that may when you get Rh immunization, it will affect future pregnancies. Cell salvage, it's been used since the 1970s in non-obstetric hemorrhage. There had been concerns for amniotic fluid embolus and maternal alloimmunization initially, which is why it hadn't been widely used in obstetrics. But it is becoming more of an accepted practice. It decreases the use of allogenic blood products. The washing and the leukocyte-reducing filter eliminates the risk of amniotic fluid contamination, and the level of contamination of the maternal circulation by amniotic fluid is similar in a C-section with or without cell saver. It's not like they're able to suck up all the amniotic fluid without having some go into the open vessels during the procedure. There were 2 articles that reported severe hypotension with cell salvage, possibly due to amniotic fluid, fetal tissue, or bradykinin from the platelets after exposure to the leukodepletion filter. Unclear the cause. But cell salvage is okay in OB. So when you are in a case and you think it would be important, call your anesthesia monitoring to help you set that up and facilitate that. Excuse me. So what have we learned? Hopefully you learned a little bit about the leading causes for peripartum hemorrhage, able to identify those patients who are at risk for peripartum hemorrhage, and talking about risk assessment and modification early on in the pregnancy. Early diagnosis, communication, and management of peripartum hemorrhage is key to good maternal fetal outcomes. Please, please, please talk to your colleagues, and when you have concerns, just let people know so that you can make an early diagnosis and actively manage any difficulty that you're having. Institutional management and protocols for peripartum hemorrhage should be in place. We reviewed ours at UCSD, but don't let every time there is a hemorrhage be the first time that people are thinking about it. Reviewing these protocols, having drills, all of this improves the management and treatment of patients in the future. Don't deny it happens, so just go ahead and say, we're bleeding, let's treat it. And don't be afraid. I think sometimes because a lot of our OB patients are awake, their loved one is at the bedside, you don't want to start saying, oh my gosh, how's your bleeding? We've lost, 2 liters. There are ways to express concern tactfully without feeling panicked or inciting panic in those that are in the room. But don't let the fact that our patients are awake prohibit you from opening the lines of communication. Here's just some questions, again, some board questions. Enclosure. Drugs useful in the treatment of uterine atony in an asthmatic with severe preeclampsia include A. Oxytocin, 15-methylprostaglandin F2 alpha, and ergonovine. Oxytocin and 15-methyl PGF2 alpha. Oxytocin and ergonovine. 15-methyl PGF2 alpha only, oxytocin only. A patient having which of the following conditions is least likely to develop DIC? Pregnancy-induced hypertension, placental abruption, placenta previa, amniotic fluid embolism, dead fetus syndrome. Which of the following patients is most likely to need emergency hysterectomy for uncontrolled bleeding at the time of delivery? Patient with placental abruption, patient undergoing vaginal birth after C-section, patient with quadruplets, patient with placenta previa, not bleeding for an elective repeat cesarean section, patient with an abdominal pregnancy. A 38-year-old primate patient with placenta previa and active vaginal bleeding arrives in the OR with a systolic pressure of 85. A cesarean section is planned. The patient is lightheaded and scared. Which of the following anesthetic induction plans would be most appropriate for this patient? Spinal anesthetic with 12 to 15 milligrams of bupivacaine, epidural anesthetic with 20 to 25 milliliters of 3% 2-chlorprocaine, general anesthetic induction with 3 to 4 milligrams per kilogram of thiopental, intubation with 1 to 1.5 milligrams per kilogram of succinylcholine, general anesthesia induction with 0.5 to 1 milligram per kilogram of ketamine, intubation with 1 to 1.5 milligrams per kilogram of succinylcholine. Replace lost blood volume first, then use any anesthetic the patient wishes. And here are your answers. Just as a side note with the first one, I would say that this is true on the boards, but clinically I would take hypertension over bronchospasm. But don't answer that on the boards. It would just be clinically what we're able to treat a little bit more effectively and efficiently. And then with the third question, again, that's just getting at the fact that when you have a placenta previa and a previous C-section, that's going to greatly increase your risk of having a placenta accreta. Thank you for listening. Hope this was helpful.